Hey, everybody. Welcome to the Health Babes podcast. I'm your host, Dr. Becky Campbell, with Dr. Crystal Hone. And today we have Dr. Marc Sklar on. He was amazing. We talked all about infertility. He gave us a lot of really great takeaway information. We talked about some of the common drivers of infertility. We talked about a lot of the testing you can do to figure out what's causing the issue, or, what's kind of stalling your ability to get pregnant. We talked about different things like stress and emotional components that can go along with infertility. So we hope you love this episode. So let's welcome Dr. Marc to the show. We're super excited to have you. This is a topic that so many people struggle with, and they have a lot of misleading information on. So we're going to ask you all the questions today.
I look forward to it.
So let's kind of start with how you got started working with fertility.
Yeah, it's a funny story, and one that is near and dear to my heart just because of where it's led me. But when I was in my last year of training, and we were in the school clinic and in the college clinic seeing patients, I just all of a sudden just started getting all these women's health related patients, and many of them were fertility or different types of reproductive issues, PCOS, endometriosis, that eventually would become fertility patients. And everybody else was getting like pain and whatever else that was. And so the calling kind of seemed to be a natural fit, but really the turning point for me was at the same time as I got my first PCOS patient who came into the office, I also was supporting my first telemedicine patient, which was my brother who lived across the country. And they were having some difficulties conceiving. And I was just giving them some suggestions and pointers and so forth. And luckily they were able to conceive and actually have twins. And right around the same time, my first patient who I was able to support to get pregnant was a woman with PCOS, and she came in and she was very frustrated about her weight, her irregular cycles, and the lack of support she was getting. And about 4.5 months in, we already had regulated her cycle, and she was able to predict when it was coming. But she comes in 4.5 months later, and she's like, "It's happening again. My cycle is gone, and I don't understand why. I thought we were making progress." And I just had this feeling that she was pregnant. So I sent her to the bathroom with a pregnancy test, and she came back and she's like, "I can't believe it. It's pregnant. I'm pregnant."
I love that.
It was wonderful. And I always get chills when I tell the story, because how wonderful that story was for her. And I helped her with her next child as well. How impactful that was for her. She, to this day, doesn't realize how impactful that was for me, because that really was the turning point that led me down this path. And I don't know what would have happened, but certainly that really solidified the decision. Like, this is what I want to do, because to me, there's nothing more meaningful and impactful when someone you've been helping and a couple lets you know that they're pregnant and they're able to grow their family and keep their generations of their family going and have this really special moment. It's just, magical. And so that's really what pushed me down this road.
I love that.
Yeah.
We all have those stories, right? Those
we do.
that are those turning points in our life. I have mine too. And I mean, that's a whole different story, but that's awesome. I loved hearing that. Thanks for sharing it.
Yeah, absolutely.
So, you work a lot with infertility, and we see a lot of that too, even in our practice, right? And what other common drivers do you often find when it comes to infertility? I know this is a big open-ended question, but some of the common things that you see that you would love to share with people.
And by that, do you mean conditions or beyond the conditions? More like
yes, both. Like
both. Yeah. So, I mean, generally, I think with conditions, the first thing I always like to tell anybody that's listening is, if you know at a young age that you've already had some irregularities with your cycles, maybe your parents and your doctor made the decision when you were in your teens to put you on birth control for whatever reason that was, outside of birth control,
Which happens a lot.
Which happens a lot. then I think that's a red flag off the bat to just say, well, maybe something's off or has been off, and I just wouldn't know because I've been on the pill and it's been regulating my hormones. And so I would encourage those individuals to really be proactive about seeking out help and starting to dig a little bit deeper to what's going on there. But if you're not having a regular menstrual cycle, roughly every 28 days, if you're not ovulating regularly, if your period comes and it's extremely painful and uncomfortable and heavy, these are not common things, right? So I don't want you to think that these are normal. Just because a lot of women have them doesn't necessarily mean that these are normal. Although we've been led to believe that, oh, that's normal. It's fine. Don't worry about it.
Right.
I mean, usually the statement after that is, we'll just put you on the pill. So if that is what you've had, or there's a family history that you are aware of, I want you to be proactive to take measures into your own hands and start to seek out support, because the sooner someone can actually start to address some of those irregularities and make it a smooth cycle, predictable ovulation, predictable menstruation, very little to no cramps, an easy bleed. These are all things that you should expect and should be normal for every woman. And if that's not happening, then that's, for me, the first sign that we need a little bit more support and we need to get a little bit, we need to dive deeper. Then it becomes a little bit more straightforward if you already know you've been diagnosed with something, right? Like if you've been diagnosed with PCOS or endometriosis or fibroids or cysts, any endocrine related disorder. So if you're skipping cycles and they've diagnosed you with something, or thyroid related issues, these are all triggers that should tell you, I want to be pregnant when I get married, or when I get married, I want to start trying very quickly, or whatever that timeline is for you. That should already be an indicator that you need some support. And I really encourage you to seek that out sooner rather than later. You'll be much happier when you do start trying. So that's like the first piece of it in terms of like conditions or things that are well known. But then I think we overlook, because we're so used to compartmentalizing our healthcare and our systems and our body. It's super amazing that medicine has evolved to specialties. And that is wonderful in one sense, because you get to speak to someone, hopefully, that has a lot of information about a very narrow subject. But what happens there is we don't connect our systems in that way. So we just don't think, oh, well, just because I'm having sleeping issues or digestive issues, oh, that's not going to affect my hormones or my fertility, so I don't have to worry about that. Well, it's not like there's walls and doors in those walls that allow these things to open up. Like everything's connected. The old, whatever the song is, my hip bone's connected to my leg bone, or whatever that is, right?
Yeah.
Like, everything's connected. And because of that, any system that is off over time, I've seen, will impact your endocrine system and your hormones and your fertility. So I don't mean this to be like, oh my God, like this is, we should be worried about everything. But I think we can all be objective enough and check in with ourselves and not ignore the things that need attention. And I think that's really something that's really important. If you don't handle stress well, or you've got a lot of anxiety, or you don't sleep well, digestion's always been an issue, whatever it is for you, if that's not handled and that perpetuates over time, it's going to impact another system in the body. The question is how long will it take before it impacts your fertility? Because we're talking about fertility. Yeah. Will it be the next system that's impacted, or will it be 3 systems down the road and you've got some time potentially, before you address it? But I don't like to think of it like that, right? We all get complacent with how we feel. And we wake up in the morning and we're used to waking up and feeling a certain way. And so as long as we feel that way, we're like, oh, I feel good. Everything's fine. But if you don't know what it really feels like to feel 100%, your 100% is 50 or whatever that is, right? And so if you're always basing it off of this, you don't even know what's possible. You don't even know what the potential is. And so I would encourage you to look at those areas that need that attention and support, and really start to get that support in those areas. Hopefully some of it we can do on our own, but that's why there's those of us out there to also help and support those who need more guidance.
You just named every one of our patients.
Yes.
I know. That's why they see us.
Yes.
Yeah, it's true. And it's funny because I was talking earlier with someone about when people come to us and they say, once they start feeling really well, they go, I notice I'm a lot more sensitive to bad food, right? Like whatever, name the food. And I'm like, no, it's not that. It's that you didn't know what it felt like to feel good. And now you realize how bad you feel when you eat that food. And your level of feeling good was so much lower before. So I love that you brought that point up.
Our thresholds are so different. My wife always says this because it's not like she ate bad before we met, but our level of quality of food and everything I'm really picky about. So that's changed. And, I think we had been dating for like 2 years or something like that. And she's like, I can't have that stuff anymore. It just doesn't taste good to me anymore. I don't feel good. And that's the difference, right? Those are the sorts of things that we're talking about. Yeah.
So true. So let's kind of talk about ovulation. So can you talk about some of the reasons that you see women don't ovulate?
Yeah. So, polycystic ovarian syndrome is the first thing that comes to mind. And that's the most common reason that I will see clinically. And it's hormonally, PCOS is something that's very, very common for women. You don't have to have, or women don't have to have the textbook presentation. Like when you open up a textbook and it says overweight and body hair and cystic acne and never gets a cycle or whatever, like that doesn't have to be the case. That is the textbook and that is one presentation. But about 50% of the women that we support with PCOS are lean. They, might even have somewhat of a regular cycle. And so PCOS is the more common reason why we would see that. Hypothalamic amenorrhea is another one, although certainly not as common. I would say that if I had to put something in between there, I would probably put stress as the second biggest cause. And I see a big issue, by the way, and very, very common to see. About 60% of the women who we see with PCOS also have a major issue with stress. And if that stress isn't managed properly, we'll see irregularities continue to happen with ovulation and menstruation. So that's a big one. And then thyroid as well. I mean, those are probably the top three. I'm not saying hypothalamic amenorrhea is not there, but it's definitely much lower on the list as to reasons why someone might not ovulate. But as we were talking about earlier with birth control, if women are in their teens and they're not ovulating regularly, it's like the solution is just birth control.
Right.
Versus just trying to help them manage that and regulate that better. And that's really not my favorite way to manage that thing. And look, teenagers are in this very volatile state hormonally, emotionally. And if they are athletes in any way, it's as if you kind of put all of that in a little beaker in a science room and just shook it up and just let it explode, because you see that just cause all sorts of havoc at that crucial time when women are going through puberty and hormones are shifting and changing.
Yeah. And I love how you made the point of PCOS. It can present so differently in so many different people. And people will even say to us, well, and we'll say, have you ever had a PCOS diagnosis? And they'll say, well, I didn't have this. I didn't have this. So they said that I didn't have PCOS. And we're like, no.
OBGYNs are going to diagnose PCOS by what it says in the textbook. And if you don't check off 80% or 100% of those, boxes, you won't be, they won't give you that diagnosis, but it does not mean you don't have a variation of it. Maybe you don't have the full-blown syndrome, but you have a variation of PCOS.
Yeah. And then we find supporting blood sugar and the things that you do for PCOS tend to really help these people.
Yeah, absolutely. And that's where like running the labs that we would run makes so much of an impact, because you can see exactly where they need that support and what's going to get them the results that they're looking for. So
exactly. Yeah. So you mentioned labs. I definitely, especially for listeners, who are struggling with fertility and they're like, okay, where do I even start? So when you have a patient come to you who's really struggling, where do you start with testing and labs? What should they be focusing on?
Yeah. So I like to get as much information as possible. And it's, most OBGYNs are going to run a very narrow panel. If we're lucky, that panel will include estradiol and FSH. This day and age, I don't know any OBGYN or fertility doctor that will exclude AMH, anti-Müllerian hormone, but that might be like the breadth of what's done. It's pretty small. And that's certainly not enough to get all the information we need, especially if we go back to the earlier part of the conversation, where we're trying to look at all the systems and see how they're impacting your endocrine system, then we need as much information. So, a full CBC panel, a comprehensive metabolic panel, full thyroid panel. And by that, I mean all the thyroid hormones and antibodies.
Amen.
And antibodies.
We're preaching, right? We want to look at vitamin D and inflammatory markers and iron levels. And then, and so all of that is not even talking about the hormones that we just started off talking about. So we always want to look at FSH, LH, estradiol, DHEA, testosterone, prolactin, sex hormone binding globulin, AMH, if I didn't mention it. So these are all the ones that we absolutely need to look at. And that's just from blood work, because then at that point, then we say, well, what else might be impacted, and what other labs do we need to do that are more functional labs, not conventional labs, that would be helpful? That might be stool testing. That might be organic acid testing. That might be a Dutch test. These are all things that are going to be important and valuable depending on the individual in front of us and how they're presenting. And I think that's really valuable. Now, that's all basically blood or urine or stool tests and so forth. That aside, I do think every woman needs to have their ovaries evaluated. Not their ovaries, sorry, their fallopian tubes evaluated. So we want to have an HSG done or a bubble test just to make sure that those are open. And then we can't ignore the man here. So if your partner or husband has not had a semen analysis done, that needs to be at the top of the list. I can tell you countless stories where that's never been tested. And then lo and behold, we find that there's an issue there. And for those listening, that is becoming much more of a problem every year. And there's been a huge decline in male sperm quality and count over the last 50 years. So, any man who is not open to giving a sample and getting tested really needs someone to knock them over the head and get them to go out the door and do what they need to do. It's a small little thing that they can do to round out the picture when we're trying to gather as much information as we can.
And it can be fun for the man to go do that.
I can tell you some stories. It could be fun to a certain extent, as long as no additional bodily fluids are exchanged. I think we can make that work. But 100%, there could be help.
It's a lot more fun than what we have to go through.
I always tell them there's no other test I know of where someone gets to orgasm while giving their sample.
It's the truth.
Amen
to that.
Is it a bit awkward to aim into a cup? 100%. But it's not that bad.
I love it.
Yeah.
So, stepping a little bit outside of lab work and all that, where else can people look, or where else can they start when it comes to infertility? I know you mentioned stress. Any other?
I see digestive issues play a huge role. And I could say hundreds and hundreds of stories of women who we just cleaned up diet and supported their gut, and they were able to conceive. And these are stories I hear every day, as I'm sure you do too. So the gut for me is a big, big one that comes to the top of the list. So gut, stress, some basic things. If we're just not sleeping, your body's not going to function properly. So you need to make sure your sleep is on point. The other part that I think is really important is, which we're seeing more and more, and I think this, when I talked about male fertility declining over the last 50 years, this is why it's happening, is environmental toxins.
Yes.
We just need to clean up our environment, and just doing one thing every week or one thing when you have an opportunity to swap those things out is going to be hugely impactful. Getting rid of any chemicals that you're using in the yard, like Roundup and all these pesticides, there's lots of natural ways you can do it. Also, It doesn't hurt you to go out there and pull some weeds and get some exercise. So, there's other ways to do it besides the lazy way of using Roundup, but Roundup's terrible for our health. And so these are real reasons why we're seeing, if all of us as a society just improved our sleep, reduced our stress by not trying to do more. I'll harp on this for just a moment. Like, everyone's like, what can I do to manage my stress? What's another technique? My biggest thing is not adding something else for you to do to manage your stress. Like, okay, so now I'm going to ask you to meditate or whatever it is. I'm going to ask you to journal. I'm not saying those things aren't useful.
Right.
Totally helpful. And I love those mechanisms, those methods, but now I'm adding one more thing onto your plate to do, which I think, we're trying to reduce our load, not add to it. So I think trying to thin things out and reduce what we're doing and not trying to always accomplish more, I think that's really important on managing the stress piece of things. If we just ate good food and make sure our digestive system was working properly and we took care of all the toxins in our environment, so much of our health issues would just subside and go away. And hopefully people wouldn't need, all of us to help them. But I think those foundational things are really, really key and can have huge, huge impacts.
And I don't think people have any idea about, the products they're using and to clean their house and put on their body and fragrance and all that type of stuff, how much that impacts our hormones. I mean, and other people's and your kids, all that, so we want to shout that from the rooftops all the time, because I don't want that to be around that, and people really don't understand what they're doing to themselves too. I mean, we've had so many patients that we start them off with a clean diet, working on switching out products in their house, working on reducing stress by even things as simple as just start saying no to things that you don't want to do. Right.
It's a great way.
And they're waiting on their, because we do the Dutch test, we do, gut stool testing and blood testing on that. And we're waiting on that to come back, and they're pregnant. Right. They get pregnant just from those things, and they can't. And we're like, well, we got your results. You can't do anything.
We see that all the time as well. And that's my point, is those just what I would say are simple, although they're not simple things, but basic things to do, could be hugely impactful in regulating our health and fertility.
But just a side note, we always really talk to people about if they can hold off getting pregnant until we can clean up the gut, how huge that is, because there is a correlation between gut health and the health of the baby and all that stuff too. So
that piece is
important.
That piece is so important, which we don't really think about. And I do have that conversation quite often with couples. It's just, your health today, your health leading up to your conception, and your health during your pregnancy is a huge impact on the health of the child that you're about to have and raise. And so, and it's not just the impact on their, on them, it's the impact on their children as well.
So true. I've seen studies on that.
Yeah. This generational thing we've gotten away from, and we need to really recognize how much of an impact we have, both positively and negatively, on generations to come. And hopefully that will make the switch happen of what we do to ourselves and to the environment we live in.
Yeah, I was reading something a long time ago, and it was talking about the food you eat, how it affects your grandchildren, not just your children, but your grandchildren. And it was wow, that's deep. You know what I mean?
Yeah.
For sure.
True.
So for listeners too who've been on the fertility journey for a long time, we often hear of Clomid and letrozole, these different medications. I was hearing you explain this. You explained it beautifully. So for listeners, who've been on this journey, who are taking these things, they don't even understand the mechanism between them sometimes, because can you kind of explain the difference between them, when often they're being brought in, and just talk about them a little bit?
Yeah. So, Clomid and letrozole, but more specifically, typically Clomid, is the first line of treatment for any OB.
Yeah.
Your gynecologist is limited in how, I should say, 98% of gynecologists are limited in what they can do in the way they practice with fertility, because it's just not what they typically support. Their practices are built around supporting other gynecological conditions.
Yeah.
Nor do they have the technology and training and time to support you properly if you need more advanced treatment. And so typically they'll say, well, I'll start you off with Clomid.
Mm-hmm.
This is going to help you ovulate.
Mm-hmm.
And I think we take for granted. So a lot of women will say, okay, that sounds great. So this is going to help me get pregnant. Well, if you're already having a regular cycle and you ovulate regularly, do you really need help ovulating? And so I just want that to settle in for a moment, right? Because the answer might be no. The answer, yes. And I think the answer becomes yes is typically in a regular cycle, you're only ovulating releasing one egg. With Clomid or letrozole, your odds of releasing multiple eggs do increase. Mm-hmm. It's not always guaranteed that you're going to release multiple eggs, but it definitely does increase. And so that can be a benefit too, because now you've released multiple eggs. You have a higher chance of conception. Now, typically with your gynecologist, there's going to be very little monitoring when it comes to this. They'll say, take this for 5 days. You take it at the beginning of your cycle for 5 days, and it's stimulating your pituitary to raise the level of FSH, follicle stimulating hormone, to allow those follicles to grow and mature a little bit more rapidly, and hopefully more of them. And so when that happens, then they just say, maybe some will do an ultrasound to see if you're getting ready to ovulate, but typically they'll just say around this time of day, go home, this time of your cycle, have intercourse, or take an ovulation predictor kit, and when it peaks, have intercourse, and off you go, and hopefully that works. That's typically the first line of defense, and that's typically done for 3 cycles in a row to see if it's working. From there, then your OBGYN will pretty much say, if this didn't work out, I think your next line is going to be insemination or IUI, and they'll send you off. Most of them will send you off to the fertility clinic to do that. Now, they will typically, if you're going to do IUI, they will still typically start off with Clomid or letrozole. Most clinics will cap off at a certain amount of cycles where they allow someone to use Clomid for. There's been it's old research, but there was some research to show that Clomid could lead, repetitive use over 6 months of time could lead to some cancer. And so there's been some concern over that, and people pull back. There's been other research or other practices now that don't really follow that anymore. I tend to be cautious with it. And so I also think Clomid, and have seen Clomid tends to have a lot more side effects for women.
Okay.
Versus letrozole, emotional side effects, PMS, and so forth. And so, there's only so much someone wants to also deal with that. Yeah. And the other time you'll switch is if you're really not seeing multiple follicles mature with Clomid. And so then say, well, let's just try letrozole to see if that's going to be more helpful for you. I've seen much less side effects with letrozole, so I like to go there first, if possible. But those 2 forms of medication are also common to use for insemination. The difference is that you'll be monitored theoretically more closely at a fertility clinic for that. They'll do more ultrasounds to see how things maturing. And then they'll also give you what's called a trigger shot to help you ovulate and mature that follicle at the end to allow it to help it rupture. So it releases the egg so that you can time your insemination more exact with ovulation. So that's typically the first line. The next step from that, if you even get to that next step, and I can go into that, is then they would go into injectables, where instead of giving you something like Clomid, where it's going to stimulate your pituitary to produce FSH, they're going to bypass that and just give you FSH, and that's what the injectables are, to mature those follicles. And for sure, then you're monitored much more closely, because that's similar to what you would do during an IVF cycle. But we're lucky if we even end up with some of those procedures in the beginning. If you're referred to an IVF clinic, typically they'll just, once they do their workup for you, their business is IVF, not IUI. And so they typically will just end up, suggesting to do IVF for one reason or another, and pushing you there sooner rather than later, for good or for bad, but that's typically what happens. Yeah.
So
sorry.
Oh, no, go ahead.
Just curious. So what's the percentage that you often feel like you need to bring these in? We talked about all these other things that you do to support the body. And oftentimes once patients do that, they're like, oh my goodness, I'm pregnant, right? Like talking about thyroid health, gut health, working on our synergistic hormones, all these things. In practice, like you're in the trenches working with fertility, right? That's your niche. That's what this is what you work mostly with. When do you bring a lot of that in, do you find? Or what's the percentage?
Yeah, it's a good question. Well, I'll say that about just overall percentages with the couples we work with, about 50% are trying naturally and 50% are trying with some form of assisted technique like IUI or IVF. Yeah. But how someone transitions from one to the other. Some have come to us, they've tried multiple IVF cycles and they're tired of it. They haven't gotten results, so they want to do things naturally, or vice versa. They want to start naturally and they want to give that an opportunity before they progress to more advanced techniques if they need it. And so really, it comes down to patience and time are the two biggest factors. And I'd always prefer to try naturally forever. So I try not to let my bias get in the way of somebody else's decisions, but I will always give my opinion and give them my, how I feel about the situation. With that being said, it's like we all have our different line in the sand of where we're comfortable trying. And so I always like to ask someone to give me 3 to 6 months in the beginning if they come to me trying naturally. But that's not always possible. I have plenty of couples who say, I'm scheduled to have an appointment in 6 weeks or whatever it is. And that's how much time I have. I'm like, I'll see what I can do, but that's not, hopefully I'll be lucky if I get all my results back by then. So, So really the two biggest things is time, and patience by the couple, and that those are just challenging to deal with, because someone who's been trying for 3 years, like, I get it, I understand, I don't blame anyone for wanting to go to IVF at that point, but I think I just want the bigger thing that I want everyone to understand is what is the reality of everything. I want everyone to have proper expectations. Like, IVF is not a guarantee, and it's not 100% successful, far be it. Okay.
Right.
It's the success rates, depending on the clinic you go to, are below 50%. Most couples need 3 cycles to get enough eggs to have a transfer. Okay. And that is a different reality, I think, what people see, because you hear these stories. I can't remember who is it right now who just said she's pregnant, she's 50 something, right? Like, these are the stories you're seeing. So you always think that, oh, they got pregnant, I can do it. I'm not saying you can't do it. I'm just saying that it might take much longer than you're expecting, and that you have a reality on. And so I think that's the first thing. The second thing is all the work you're going to do to prepare your body now and hopefully regulate your hormones and correct any imbalances or root causes is only going to be a positive step to help you get pregnant faster, whether you're trying naturally or with IVF. So we want that protocol. Like if you're going to spend the money, the $20,000 on IVF, I want that to be successful the first time. So what do we need to do to make that successful the first time? And that's really what I try to impart. Like, give us a little bit of time to help that make that a little bit more successful for you. And, I also think that we hear all these things about age and AMH, and the only things we hear about age and AMH are all negative.
Yeah.
Right.
Soon they're going to say if you're 30, you're, advanced maternal age, right? So like we have this misunderstanding. You're told that you're too old too soon, and you're told that you have no more eggs. And I think all of that is a misnomer and completely inaccurate. First, you can't change your age. You can only change your cellular age, but you can't change how much time you've spent on this earth, right? So forget about that. Don't worry about it. Let's focus on the things we can control.
Yeah.
We're also told that AMH is a number that can't be changed. But one, I see it change all the time. And two, I also think it's a bit inaccurate. And we have a false understanding for what it's actually telling us. And okay, so let's just say your AMH is low and it says you have less eggs than you would ideally like to have. My question is always going to be, are you menstruating and are you ovulating? If you're menstruating and you're ovulating, all you need is one egg, right? Like we're not, cats. We don't need a litter.
That's a good
right?
point.
And so if we've got one egg to work with, we just need to work on the quality of the egg that you're releasing. Every month anyway, if you're trying naturally, you're only releasing one egg. Yeah. So I don't need 20. Right. I just need one good egg. So, let's focus on the things that are more realistic for us to control. I'm not saying that we can't improve AMH, because I do believe we can and have seen it repeatedly. I'm just saying I think it's daunting for us to think about that. So let's focus on the things we can. And let's take a breath. Like if we're just rushing because we are making these decisions out of fear because that's what we've been told, right. Then I want us to make these decisions for different reasons. And so do you really need to rush into it? Is waiting 3 months really going to impact your fertility negatively that much like you've been told? I actually think it's the opposite. Right. I think if you're proactive about what you're doing, those 3 months are only going to help you, not hinder you. So very true. It's about perspective. It's about time and patience. And I think those are big pieces that need to be accounted for. But I'll never get in the way of someone who says, look, I've been trying for 5 years. It just hasn't worked. Yes. I think it's time for me to go to IVF. I'll support you 100%. I just want you to have your eyes wide open when you go to it. That's all.
I do find that many people who decide that they want to get pregnant, even if they haven't been trying for a long time, they're very adamant about wanting to get pregnant now. You know what right. I mean? So it's like, can you give us 3 to 6 months to, get your body really, really ready for that? And some people will say no. Right. And we really have to try to educate them on why it's so important. And most of the time we can get them to agree to it. But and I think it's because of the pressure that's put on people being told about their age and stuff like that. They're like, I only have a small window. And we're like, really, your window isn't as small as you think if your body's in a better position to carry a baby and to get pregnant. So I think that's such a good point.
Yeah, I mean, we have a lot of misunderstandings about that. I think one of them comes to sex education when we're young, right? We're led to believe like if I touch my boyfriend or girlfriend, I'm going to get pregnant. Oh yeah. So it makes us think it's so easy, right? So then when we want, we're like, oh, I'll just flip the switch. I'll get pregnant now, which is not the case by any means. I understand why they do it. I disagree, but that's where a lot of this miseducation comes, and that's how it impacts us because then we want it now, right? We're also in a society of like Amazon delivers in 2 hours, right? So I want it all now, right? Like instant. Oh, what do you mean I can't have it in 2 days? I can't be pregnant in 2 days? It's not Amazon? Like
it's so true. Oh, right. That's sad, actually.
Yeah.
Well, okay. So if you had to give the people listening one thing that you could say, start this now to kind of increase your chances of fertility, what would that be?
I'd say I'm not going to pick one thing. I'm going to pick a couple. One is, I think it's really important, first and foremost, to have belief and hope in yourself. You were made to reproduce. You can do this. If we clear up the blockages, your body can do it. It's about giving it the proper support. So I see so many couples that have just their belief in themselves and their ability to conceive has just been drained from them for various reasons. And we need to take out all that negative talk that we've been told, and we need to just restore that positivity and hope and belief that you can do it. So for me, that's top of the list. That's number one. Two is we all, in most things, I can't say all, but I would like to say all, we've been successful achieving in life. We have all had guides, mentors, coaches, teachers, whatever you want to call them. We've had them. And this is no different. You know, if you've been trying for 6 to 12 months and there's just so much information out there, not all of it is pertinent to you. We all need someone to help us filter through that, determine what we really need, and guide us through that process. And someone who's done it, right? And has been there and has walked that road for whatever amount of patients that they know what they can do for you. And this is no different than, you know, studying to get your degree or get that promotion at work or be successful in whatever you want to do. We all need guides and coaches. This is no different. And I think that's a really important piece because there's so much information out there. It's really difficult to understand what we need as an individual. So those would be the two kind of big takeaways that I would say.
I love that. Those are so good.
Yes.
Thank you so much for coming on. Like, where can people find you?
Oh, thanks. Well, the easiest way is my YouTube channel, Fertility TV. I put out a new video every week. There's hundreds of videos.
It's amazing. You have a really good YouTube.
Thank you. So that's first and foremost. Outside of that, I'm on Instagram and Facebook and very, very little on TikTok.
We feel you on that one.
And then my website, which is marcsklar.com.
Awesome. Thank you so much for coming on. This was amazing. Listeners are going to get a lot out of it, and you were just wonderful. Thank you.
Oh, thank you. I hope they find value in it. And thank you so much for having me.
Of course.
Thank you guys so much for listening to this episode. And if you love this episode, please leave a review. It only takes a couple minutes. And you can find out more about us on drbeckycampbell.com. And you can follow us over at Instagram on @HealthBabesPodcast, @Dr. Becky Campbell, and @Dr. Crystal Hone. Have an amazing day.